take a break, have an espresso, and come back in 10 minutes. Welcome to the next episode of Endoscopy Essentials. It's a very special episode. We do it with the start of the Düsseldorf Symposium, and it's a partner episode with ERBE. I'm very happy to welcome my old friend and co-founder of Endoscopy on Air, Alessandro Repici. Actually, the last episode we did, Ale, was quite some time ago, and it was a biography, and it's still one of my most memorable experience. So welcome back for an endoscopic topic, Ale.
Oh, good. Ciao, Thomas.
So I remember you were saying some time ago that CO2 endoscopy is a historical mistake and things are turning to underwater endoscopy. Can you explain why?
Yeah, first and foremost, thanks for giving me this opportunity. Also let me sincerely congratulate for these recordings that you have made over the last couple of years. You have built a sort of memory of past endoscopy and past endoscopies, but also you are working in showing to everybody what will be the future of endoscopy. So I'm really so appreciative of what you're doing. I think it's unbelievable. Anytime that I see there is a new recording on YouTube, I get connected overnight and I listen to this and I watch, and I can see so many superstars talking about their life and their endoscopy, their practice. It's beautiful. One of the things that I still remember when I was young as a fellow, I was struggling to see the face of Maynard Klassen, of people like Soendra, Age Mueller, the stars of endoscopy. And now I'm still so curious when there is a new face to see the face, to see how they talking, what is their practice. And this is something unique. And I have to blame a little bit the new generation because they know much less about the true story behind the people who are leading the field of endoscopy. So what you're doing is creating the strong memory for everybody, and everybody new can have a look and understand what is going on in the field of endoscopy. So having said that, go to our topic,
Thank you.
underwater. Underwater. Yeah, but that was important to me because it's something that is touching me, what you're doing. So underwater. So the question should be to you, why are you asking me to talk underwater? So yes, it's true that we have been talking about underwater endoscopy since a couple of years. Let me say very clearly. So I think both of you, we were trained with air. So through the endoscopy channel, we were pushing pure air into the lumen of the colon, of the stomach, and whatever.
And
And
colonoscopy was a very bad experience for the
I,
patient.
I can say yes, you're right,
For
you're right.
hours afterwards, yes.
Yeah. So post colonoscopy, but also during the procedure,
Mhm.
I will remember patients with ballooning of their abdomen, huge distension, increased risk of complication, including perforation. But at certain point, and this is also part of the evolution of the medicine, we realized this with the laparoscopy, that CO2 was a gas that was quickly reabsorbed through the tissue at different level. And this is where there was a big shift. If I don't remember well, it was around 2010. There was a big randomized trial from the Oslo team, I think.
I think
Um,
the Oslo people started early,
yeah,
and then that's one of the few areas where all randomized studies were positive, really all of them,
yeah.
small
Oh,
ones,
yeah.
big
There was
ones.
no doubt. There was no doubt. So in the beginning, we understood that that was the way to go. So the randomized trial showed clearly that the post-colonoscopy pain was uh, very limited in comparison with the air. That there were multiple endpoints that were taken by the study, not only the first one, but multiple studies. At that point, the limitation of switching everybody to CO2, that there were no endoscopy suite that were equipped with CO2. So the CO2 came slowly into the endoscopy unit. So until I would say 5 or 6 before COVID, there was still in different parts of the world endoscopy division that were not using fully the CO2. But anyway, I would say that after the trial, after other trials in colonoscopy, especially everybody switched to CO2, and all the company, all the vendors were starting including in the package of the endoscopy tower the CO2 as well. But still, I think this is not as good as should be, because it's true that CO2 is rapidly reabsorbed, but still creating um, lumen distension, uh, wall tension, and I don't think it's replicating the right context for the endoscope to move into the different organs. And this is where I was looking to the previous past studies on underwater colonoscopy, trying to understand the potential advantage. So I think there was evidence for underwater colonoscopy since 10 years ago, probably a little bit more. There was especially an Italian group based in Sardinia. The name of the guy is Sergio Catoni. Sergio was one of the first publishing randomized trial with underwater colonoscopy showing the different advantages of using underwater. But indeed, the big shift was when we realized the value of using the water for therapeutic endoscopy. And that was probably one of the major changes in the field of endoscopy in the last 20 years, because we were considering water a problem. When you had the lumen filled with water, you were trying to suck everything and to have a clear picture. Rather, we were missing the advantage of using water. So that's the story of
I
the
mean,
evolution of
the
the thought.
Japanese used it for a sort of an additional magnification effect.
Yeah.
Um,
Yeah, that's true, because water is amplifying what you're seeing, and you can see better, especially the pattern details. That is probably what the Japanese meant using underwater. But in general, you're right. They started, but only for optimization of the quality of the view.
so your impression was that we are not dealing with a natural organ, natural colon, for example. It's over distended, and but
Yeah,
isn't that what we
colon.
initially wanted? Distended, everything visible. So how did you get back to water? But it was, if I understand, it was mainly for therapeutic purposes.
No, no. First, let me answer to the first part of the question. So, basically, colon in normal situation is filled with some form of liquid contents, no? And most of the reabsorption of the liquids they come into the colon. So potentially colon is optimal organ where to use water, because this is how the colon works in a typical situation, in physiologic condition. But of course, I think that using water is good also in other different situations, including small bowel, esophagus, and stomach. Because when you use water, so basically you reduce significantly the pressure against the tissue. So the tissue is not over distended. So I will say this is creating exactly the same condition of the tissue, not with the scope inside. So you can reproduce a very physiologic situation,
Mhm.
and this allowing you to appreciate things that normally you cannot appreciate first, and second, to advance into the lumen of the organ in a much faster way, in a much smoother way, without or creating much less pain, much less discomfort as compared with the CO2.
So, in a kind of a summary, you are working more in the natural habitat of
Exactly.
the GI tract.
Yeah.
A few things before we go into details and current application and this and that. It's not water, it's saline, isn't it?
Yeah. Yeah.
For all in all instances.
No, no. For diagnostic purposes, we use regular water, sterile water.
Mhm.
For therapeutic is right. When you need to use electrosurgery, it must be saline because the ions concentration is much better. And this allows the current to be diffused through the medium, to the saline much better. So the interface with the tissue is improved. It's better than with water.
The other question when starting this and speaking to other people, there's always a hesitance. Can it be dangerous? Too much fluid absorption, too much volume. Do you have to control? Do you have to
Yeah,
stuck it out? So,
this is a good
what are the
point.
general principles?
This is a good point. I would say we need to differentiate diagnostic from therapeutics. Diagnostic, the amount of water you're using is minimal, for doing underwater colonoscopy. You reach very quickly the sigma. It can be 3 to 4 minutes if you use the right technique. At that point, you don't need to use any longer water. You're just sucking everything, using CO2 to distend the lumen, and watch carefully and try to identify as much as possible adenomatous polyps. So I don't see any problem
For the volume.
with the volume. For therapeutics, you're right. It depends, of course, on the situation, and it's related to the duration of the procedure. If the procedure is going to last long, you have to take care of a couple of issues. First, you have to measure how much water you are using and how much water you are sucking, so there must be a balance. And also, what we're seeing that when you do therapeutic procedures underwater, body temperature goes down.
Mhm.
So what we do constantly, we measure body temperature, and normally we're coating the patients with a blanket that is with a heating machine, which is providing a constant body temperature to the patients. What is the difference? We didn't do like this. And when they wake up after deep sedation, they have very, very important discomfort. Different kind of discomforts. It was not only pain, it was sort of a general discomfort, no? Rather, when you keep the patient at a constant body temperature, the the way they wake up is much better. They have very little discomfort or no discomfort. And of course, you have to take care of a couple of issues. So the balance of the water is important. But we also sometimes, when it takes a couple of hours, we do blood tests in the meantime, or we do hemogas to check if there is any imbalance.
And do you warm your saline before you infuse it?
We don't warm, of course, no.
But one could, huh?
In Western countries, in the endoscopy rooms, the temperature is always over 20 degrees. So if you store the saline in the right place, it can be 24, 25 degrees Celsius. So I don't think we should warm too much. There are people, I've seen people warming a little bit. So the problem that we have, it's difficult to understand exactly how to measure the temperature of the water. We do not have the system in place, but they can be doable.
So the message is think of volume, control the volume, and think of the temperature,
Body
and either
temperature.
warm the patient or the saline or both.
Yeah, yeah,
And
on both
and
sides.
and number three is do some lab checks, especially if you have a longish procedure,
Yeah.
ESD somewhere high up in the
And also it
colon.
depends on the patient, you know, if the patient is fragile, is a renal insufficiency. So, of course, you need to pay attention to a couple of details before.
Right. This touches upon another issue I'm very passionate about. That's using general anesthesia
Hmm.
for the longer procedures, because then you also have a better surveillance naturally. So, but that's not our our topic
No,
today.
but no, no, but I take this point. I would say for upper GI therapeutic procedures, we use general anesthesia all the time. If you need to use underwater, under saline, there is no doubt it must be done with a under saline approach. For colorectal lesions for big ESD, big EMR, I would say that when I expect the procedures being longer than 1 hour, one and a half hour, 2 hours, I now prefer to intubate the patients because the feeling is that you have a much better control of the
Mhm.
patients.
Absolutely. I couldn't agree more, but that's still an ongoing debate and
Yeah,
very different habits between countries and areas and so on and
yeah.
so on.
Of course, we can do that because we have availability of anesthesiologists in the room, and not everybody has full availability of anesthesiologists every day. So if you have a busy practice, you have to do ESD every day, that can be a problem.
Right, but that's a kind of a negative self-fulfilling prophecy, and I think we should get
Yeah,
out of this finally. Yeah.
yeah, yeah.
Okay. Next general issue is what happens if there's a perforation, or what happens if you're working outside, like in poem. Do we have to be
Mhm.
afraid that the allural effusions or the mediastinum gets over flooded, or do you do your poems underwater as well?
No, so one of the first time that I realized the value of underwater therapeutic procedures was in San Francisco. I was in San Francisco. I don't remember why, about 10 years ago for a meeting, and went to visit Campbell Meller.
I mean, he has to be given credit for this as well,
Yeah,
to a
yeah.
great extent.
He is the visionary for many things. So of course, from all taxi, but not only. So I met first time Ken in Hamburg, your own place,
Quite some
probably
time ago.
was in 1996. He was doing spectacular US at that time. But anyway, so he doesn't need my credit. But when I went to San Francisco, I think it was 2015 or 16, I don't remember, I saw him doing underwater polypectomy. I was fascinated. And afterwards, he came to Milano for one of the image event. He performed the first, I think it was in Europe the first time, first underwater poem. So at the dinner, I was discussing with Ken, saying, Ken, I'm scared because you know all this water flowing into the mediastinum if you have full thickness myoma. He reassured me, he's very calm, very pragmatic. He gave me very good evidence to the fact that using saline, sterile saline, should not be a problem, whatever the fluid are going, because they are quickly reabsorbed.
So maybe, when you want to start this, don't start with poem.
No, because uh, of of course Ken is an artist. He's out of any scale, so he can do very quickly with the underwater approach. I've tried several times to do underwater, and I don't think it's easier than doing with the CO2. I think with CO2 it's still a little bit easier unless you have a significant fibrosis because um, with the fibrosis, avoiding the tension and opening the space
Mhm.
with the water, it allows you to create a easier tunnel. But of course, there is another reason that can that should push us to use saline during the poem. You know, there are sometimes situations where the anesthesiologist is warning you the CO2 level is going very up, no, and the patient is start not doing well, and they say, okay, you have to stop the procedure because the CO2 level is extremely high. At that point, what we do, we switch off the CO2 and we keep going with underwater. It helps a lot. CO2 drops quickly and you can proceed with your procedure so you're not delaying too much. Even though we are doing myotomy, we do the myotomy underwater. And I think this is another reason or another indication to switch to underwater when you're in trouble with the third space procedures and CO2 is extremely high.
That's a good point. There's, by the way, an alternative to that. Take a break, have an espresso, and come back in 10 minutes. Then it's
Yeah,
also
but you know,
done. But
everybody's under
yeah.
pressure for
And
the globe.
one thing I found quite useful in poem, there are these advanced chelators with a very firm muscularis, and the entry can be very difficult.
Yeah, that was when I say fibrotic.
Yes, and
At
so
that
the
point,
entry, if you can't entry, use
yeah,
water. And
exactly.
it comes back to the same thing you were explaining, that it's not so extended. So you have a more natural space, and it might be easier to get access because there are these few cases with really tough entry.
Can't agree more. So
Okay,
you
good.
totally.
So let's go to the core topic of this
Mm.
partner podcast with RB. That's resection. Because that's
Hmm.
another thing when you hear about underwater, under saline, you say, what? Current underwater? How should this work? Does it kill all the current? And you were instrumental in cooperation with Erbe in developing certain currents. And when you speak to different underwater people, actually everybody uses something slightly different, and there are different tricks for the vessels. And so please tell us a little bit of your secrets.
No, I think there is no secret. So what I learned is that, of course, watching can be better using a regular current, but also
For
if you look
EMR.
at the, let me finish. When you look to the paper, the study published in gastroenterology by the group of Helmut Messmann, the underwater polypectomy. They basically adjusted the dosage, the current, but they were using standard polypectomy setting. So I think for us is the same. So we worked with Herbe, and we very grateful to Herbe in this regards, especially try to understand which of the modality already available in the new machines were working better in the underwater under saline setting, and what we use is Swift. So with the Swift we do we get very nice effect, and I would say we replicate exactly the same effect that we have with the CO2. The difference is with the coagulation. You should go a little bit down with the coagulation effect because water is helping in spreading the energy in a wider way. So if you use high voltage, you coagulate a lot and you are spreading too much current to the tissue, even though the tissue is cooled down by the water. So water can also help in preventing damage. But in general, we are reducing the voltage of the coagulation. So it depends on the kind of value that you have. You have to go down with your setting. But the future is different because you're right. If you talk with 10 experts, you will say 10 different settings, slightly different or largely different. When you remember when Burke was here in Milano for the last Endoscopy on Air, the global event last June, and they were discussing with the Pradeep Bandari about what setting they were quite distant in terms of setting, no? So I think that Airbase is instrumental now in helping us. They already um, mm, prepared an underwater setting for EMR is available in the latest version of the Vio machine. But I think that very soon they are going to announce also a dedicated setting for underwater ESD. So of course this is not extremely important for superstars like you, Bandari, Burke, so people doing this job since long, because all of you have a little trick, you know, you adjust the machine based on what you want. But for the average endoscopist, having a dedicated setting from Hermes, which is coming up very soon, I think they will announce at the SG Days, if I'm not wrong, or just afterwards. Having dedicated setting is just helping everybody. So you don't need to struggle and to test several times what can be your best setting before doing underwater resection of big colorectal lesions, but you just select underwater EMR, underwater ESD setting, and you're done.
Okay, so here the message is, so everybody used what he was used to use in the CO2 environment, and then maybe slightly adapted it, like you said, go down with the energy level.
Yeah.
And
Good
now
combination.
this new setting is sort of a compromise between
It's a
several
compromise, but it's
working groups.
also based on science. So they did multiple tests on tissue, on live animals. So they understood what is the ideal current setting using saline based on the different spreading of the ions through the saline as compared with the CO2.
Right. Because with regards to experience, Ale, if some very experienced CO2 ESD person changes to water, it
Yeah,
might take him as long as somebody who starts fresh underwater. So
yeah, you're
it,
right.
it's
No, I agree
because
totally.
you are kind of skeptical all the time and think, ah, this water and so
No, and Thomas, we are completing a randomized trial for ESD, underwater versus CO2.
on. Mhm.
And I think it will be completed within 1 month. Of course, we will submit the first Dugat because it's big trial about 120. We have to do 130 patients. We are over 100 patients. And you know what is my feeling? When I do underwater, I feel so confident. I feel good with the patients. I feel I can do a very good job. But when the patient is randomized to CO2, I feel guilty now because after having done more than 100 patients, I realize that the safest environment for doing ESD to our patients is under saline, is not under CO2. It's completely different. And I really want to complete the trial as soon as possible because I feel that doing under CO2 it's just worsening or at least potentially worsening the outcome of the SD. So in terms of speed of operation, number of bleedings, delayed bleeding, use of coagrasper, it's much less, much less.
Yeah, we're looking forward to that. I mean, the psychology of trials when you have a different idea is also interesting because you can't do this blinded. You know
Yeah.
whether you're under CO2 or water. But at the end, if the physician is comfortable, it's probably better for the patient. At least it's not worse. So,
To overcome a little bit the problem of not being blind because it's impossible.
uh,
We asked at least to 4 or 5 different physicians to be part of this trial. So it's not me, it's not you, it's not Cesare, it's not Roberta Maselli, it's a couple of people, and I would say the data are very similar regardless of the physician in charge and regardless of the experience of the physician, which is very good to me. It's a very good signal.
okay, Ale, this was a super nice introduction into underwater. It was actually a very slow travel into it with a lot of convincing arguments. I think you have taken us all. And my recommendation, I started about 2 years ago, especially in the colon and rectum, um, where it's really, really helpful. I can say so. Get familiar with it. Maybe the new settings will be helpful because they are standardized then. So
Yeah.
everybody, when somebody talks about bleeding, it's the same as the other person talks about bleeding. And we're very much looking forward to the results of your trials
Yeah.
during ESG days or whatever. So thank
No,
you,
and
Ale.
I want to add a single point. No, if somebody asks me what is the disadvantage of using under saline or underwater, whatever you want to call it. So it's when you get big bleeding. So at that time, mm, don't be shy and just convert it to CO2. But if you're doing underwater, you are recognizing properly the vessels, whatever is artery or veins. Okay? Underwater is allowing you to see that very clearly. If you use the technique of pre-sealing of the vessels, the risk of torrential bleeding in underwater situation is much, much less. You remember some spurting bleeding in USD that you can't see anything, you are flooded by the blood. This comes much, much less in undersaline condition. This is extremely good. And also, the reason when you get big bleeding, the reason why you should switch to CO2 is because you may need to use coagrasper, and this must be clear to all physicians. If
Mhm.
you use coagrasper underwater, it's not working as well as under CO2. I do not know exactly why. Of course, we need more tests on it, but our feeling was that we were using for big bleeding coagrasper underwater. It didn't work as well as under CO2. So we need more evidence, of course.
Thanks for adding this. We almost forgot this very important question. What about bleeding? So the message here is the likelihood is less, and unless it's torrential bleeding, where you have to go back to CO2 and soft coag and co-grasper or whatever, it's probably the minor and middle, the moderate bleedings are better managed under constant water or saline infusion.
Yeah.
Okay, Ale, again, thank you so much
Hey,
for this
Thomas, thank
nice
you so much.
introduction, and
We'll see you soon.
hope to have you back soon. Thank you.
Ciao, ciao.